for our next session, actually I asked Dr. Mark Blatt from Intel to come to the stage. Dr. Mark Blatt is Intel Medical Director worldwide. Is that right, Mark? And also we're going to have Javier Ferrero from the Andalusia Healthcare Quality Agency sharing some of their experiences on what they did in terms of mobile health. And Javier Ferrero, who's the CIO there, will have a conversation with Mark. And then at the end, Scott will facilitate some Q&A. Thank you, Mark. The floor is yours.
Thanks. I'm going to give you a little bit of a talk on maybe what an answer might be to a hospital of the future. By training, I'm a family doctor in the United States. I practiced about 20 years. I became convinced that one could do healthcare differently on a Saturday morning when I took call for about 12 other primary care doctors. I probably received 150, 200 phone calls in the morning. And I was able to talk to people on the phone back in the mid-90s with no electronic records, no video, no real tools, and treat maybe 75% of the people in about 1 to 2 minutes after a quick conversation on the phone. As a result of that, I became convinced that there were ways to treat large numbers of people very inexpensively. And I started to wonder what I was doing in my office on Monday mornings and why I was actually bringing people face-to-face in to see me, which got me to think about this idea around collaboration. And what I want to do is talk to you about collaborative workflow. Different people in different venues working together, collaborating in manners that they don't work together now. If you want to lower the bed days of care by 30% in your hospital, collaborative workflow can already do that. And I can show you the evidence in a half a dozen cases where it's done it by 30% or 40%. I don't have enough time, so I'll give you 1 or 2 examples. I'm going to start here with a video that I want to play, which will give you about 2 minutes of an example on collaboration and what it means in 2 specific workflows.
Secure mobile computing has already had a profound impact on medical care, at home, in medical transit, and in the hospital. Now, by enabling rich, multi-way video collaboration, the latest high-performance, ultra-mobile systems can help further improve medical outcomes, reduce hospital stays, admissions, and readmissions, simplify patient transfers, and greatly improve the effectiveness of care providers. Let's take a look at 2 areas where rich, real-time collaboration could make a big difference, avoiding unnecessary trips to the hospital and avoiding a patient readmission. Imagine a boy who was recently treated for pneumonia begins having an asthma attack. His mother calls for an ambulance. Using an Ultrabook, the EMT immediately places a call to the child's physician, enabling her to see the child via video. While the doctor begins pulling up the boy's meds list, she asks the EMT to have the child breathe into a spirometer, the results of which are also streamed to the doctor's Ultrabook in real time. The doctor determines the attack isn't severe and realizes one of the child's meds may need to be adjusted. She tells the EMT to let the child use his inhaler and makes an immediate change to the child's script. She then asks the EMT to monitor the patient for 20 minutes, repeat the tests, and call her back. In this instance, real-time video collaboration and concurrent streaming of medical data delivered far greater insight into the patient's condition in far less time, avoiding a potentially unnecessary and costly ER trip and subsequent hospital admission. Now imagine an elderly patient being discharged with an acute condition after a brief hospital stay. To ensure optimal at-home treatment and put the patient at ease, the discharge nurse sets up a video conference with the woman's nurse practitioner, her son, and the home care nurse assigned to her case. In just a few minutes, all parties are completely up to speed on her history and condition, including detailed imaging results, as well as her ongoing treatment, her required appointments, and any warning signs and symptoms. The result? The patient, her family, and clinicians are much more comfortable with her returning home. In this case, real-time video collaboration and multimedia data sharing greatly increased the understanding and comfort level of all parties involved, helping to potentially avoid an unnecessary and costly hospital readmission. These are just a few examples of how rich.
So what I wanted to show you there was the idea that two things have changed in the last 3 years since my experience in the 90s. Real-time video conferencing is pretty inexpensive and pretty easy to do. How many of you guys use real-time video conferencing at all in your personal life? Skype? Yeah, well, God, half the audience is raising their hand. This is unimaginable 2-3 years ago. It's become that simple and that easy to do to multiple devices. I gave you one example of a device. The second thing that's happened is the ability to stream medical data live to any device from any location. So what I was showing you, by bringing these two things together, I can get real-time collaboration for multiple actors in multiple venues across firewalls to do things that we don't currently do. You don't have current collaboration between home care nurses, social workers, community workers, and hospital workers. A big goal in the NHS in England right now. You don't have patients intimately involved in their clinical decision-making by bringing family members who are remote into the clinical decision process routinely. We might do it at extraordinary, but I think it becomes routine going forward. Right now, clinicians follow evidence-based medicine. They do a great job taking care of patients one at a time as they're presented to them as individual actors. And I'm here to tell you that's not good enough going forward. That's actually the baseline. That's what I expect. I expect all clinicians to use evidence-based medicine and get it right 100% of the time and never ever get it wrong, and to give me convenient care. But if sitting in your office and waiting for sick people to show up is what you think your job is, that's a 19th century business model. This is an example of patient-centered medical home criteria from an organization in the United States called NCQA. I put it up here not because I want you to read each line. It's got 9 different domains. Domain 3 is about patient care. It's about evidence-based medicine protocols, care pathways. This is what we spend 90% of our time in medical school teaching our clinicians, doctors, nurses, therapists, whoever. And it counts for about 20 points in the model. The other 80 points I think they need to observe by osmosis. They're not being taught this. Patient tracking, registries, test tracking, electronic prescribing, performance tracking, referral tracking, basically tracking and coordinating the care. Now, if I told your expert doctors that was their job, they might cross their arms and look at me with a huff and say, that's not my job. And I'm telling them that's 80% of their job going forward, is collaborating and coordinating care. That's where the dollars will be saved. That's where the improvements are going to be met. And I'll show you some of the evidence for that. This 20%, that's what I expected them. This is a cultural change. It's not a technology change. I'll show you the technology exists completely to do that. It's not a problem. You can do this collaboration now. But the cultural change to get people who are not used to collaborating, who are used to doing great jobs by themselves and then tossing it over the wall and hoping it works, that's the fundamental change. The job that our clinicians are about to do in the next 20 years, in my humble opinion, is extremely different than the job they've been taught and the job they've been doing for the last 200 years since Vienna came up with the idea of hospitals in the 1850s. We really haven't fundamentally changed the workflow. Now, what if you do get to this collaboration model? I showed you 2 ideas: avoided trips to the emergency room and avoided readmissions. This is one of the ways I get hospitals to shrink as a first step. This is a study out of the American Academy of Family Physicians back about 3 years ago, where they put patient-centered medical home principles on patients. And if you had a patient-centered medical home, about 4% of your patients ended up in the emergency room. If you didn't have patient-centered medical home principles, if you weren't available and interacting and with the patient, about 21% of the patients ended up at some point in the emergency room. That delta alone could probably fund so many of the changes that we're looking for in collapsing spending. Truven Health did a study about a month and a half ago, and they had the most preposterous numbers I ever saw regarding this. They claimed that approximately 80% of people who end up in the emergency room don't belong there. That's tremendous, and that's a system-level problem, a system-level focus. It's not focusing on one disease, it's focusing on the systemness of how we actually collaborate, offer our citizens care. About 14 years ago, I remember seeing in articles coming out of the UK that the NHS was having a problem with their emergency rooms. They were actually putting up tents in parking lots because the emergency rooms were overflowing, and that led to the whole program for modernization. Changing towards patient-centered medical home and collaboration principles and actually sharing data across firewalls can make a huge difference. Here's one study, and I could probably give you dozens, and I won't. Here's one study out of California with critically ill patients, where they took patient-centered medical home from 750 patients and they applied the principles here to half the group and regular care to the other half. Look at the outcomes. Roughly 40% fewer admissions, inpatient days, and 30% fewer inpatient visits, and dramatically lower cost. Any of you facing cost pressures in your organizations to reduce spending? They were able to reduce spending 26% without having to cut your salaries or ration care. How many of your hospitals right now, if you built or designed them, could exist with 35% fewer bed days of care and ED visits? You'd probably go bankrupt. But that's exactly what you're designing for going forward. That's what you're looking at. Following the 100-point collaboration framework is where you want to head. And by no means is that easy. That's a very difficult cultural change. But I can show you slide after slide that these outcomes of 30–40% reduction in admissions, readmissions, and ED visits are reproducible over and over. It's my Saturday morning experience, just systematized and institutionalized. Now, when I talk about actually doing this and getting coordinated care, you got to do 4 things as a country, a citizen, an organization. You got to build some type of repository for gathering or digitizing data. In the United States, we're paying our doctors to do this. We call it meaningful use. We're incenting them. The Republicans might say bribing. The Democrats say incenting in the United States. We're giving them about $20–30 billion to digitize their records. We're now trying to look at building exchanges to share them. Some of your countries are far more advanced than us in building exchange systems. Mobilizing data so that any physician anywhere on any platform can view that data. And by clinician, I don't mean just the doctor. I do mean the nurse. I mean the emergency services. I mean the community care nurses. And then giving it back to the citizen and empowering them. And I'll show you some very quick data that actually shows that patient empowerment may actually have more bang for your buck than almost anything you can do here. You create this virtuous cycle of data. The more you gather, the more you can share, the more you can mobilize. And that's essentially the goal. These 4 things, if you chose to do any one, build a data exchange, develop a mobile project, a repository, you would see changes along the orders of 5, 6, 8%, single-digit, high-level changes. Unfortunately, to get these system changes of 30, 40%, you're going to have to, at some point, do all 4. I don't care where you get started. Getting started anywhere on the circle makes sense. But you're going to go to all 4 eventually. And when I talk about collaboration, I don't just mean the community hospital collaborating with the research center and sharing, let's say, images with teleradiology, or even consults using telemedicine. If you want to avoid trips to the emergency room, it might make sense, as in the video, to talk to emergency services in real time. You can't talk to them after the fact. It has to be a decision at the point of decision, the point of care. If you want to involve community health services to better keep people at home so they don't end up making unnecessary trips to the emergency room or being readmitted, you need to start to collaborate, and you need to give this information back to the citizen. This is what a collaborative platform might look like. If you had a tablet or a PC that could bring up a multi-way video conference, let's say could share DICOM, x-rays, share telemetry, and share the medical record. Now, I can actually do that on this tablet device here. This is a, if I can figure out how to turn them on, yep. This is a instant-on small little tablet, and I can actually bring up this screen here on this tablet in a multi-way collaboration platform. But since you all can't see it, I'm going to bring it up here on a fixed device, if I can get this to play. And This is just simply a demo that we put together to show with the current power, I can use security sign-on, 2-, 3-factor authentication, can carry around PHI on a mobile device, and even if it gets lost, not face a breach, be secure under both European and US law. PHI on a mobile device and not face a breach. The technology's there. You shouldn't be afraid of it. And I can do something like bring up the telemetry. Okay, I can do that on almost even a consumer device. But now I can bring up two things side by side. And if you're a clinician, a specialist in the hospital, and you can view telemetry and DICOM remotely anywhere you are, side by side, your decision-making might start to improve. What if then I can add the EMR technology? I can open up another window. What if I can then add a communication package? All of this is doable. And what if then I could use the communication package to have a multi-way video conference? I could call a patient's daughter at home to talk about the surgery the patient's having. The daughter's really nervous. I can bring in the second doctor. And the patient doesn't have to come in and wait for hours, and the only time she's visiting is 5 minutes after you left. And then I can actually bring in the team, no decision without me. We can start to collaborate in real time with all the data available, and I can transfer large files using a system like Link. We made up the word here, sync. Didn't want to have to pay Microsoft any royalties, but it's essentially Link that we're dealing with here. So that's what a collaborative workflow might look like, and I could bring this all up on this tablet. And the other thing on this tablet, I've loaded Nuance, and I can use command and control. I can open up the telemetry, the DICOM, by simply saying EMR, DICOM, telemetry. I can open it up all hands off. So I could walk into a room and be looking at you, the patient, and say, bring up Jose's DICOM. I don't have to be heads down. I can maintain my eye contact with the patient. Actually, today in San Francisco, Intel is launching a whole set of tablets and processors at our major event that all, by standard kit, include voice command and control. It's not an option anymore in the PCs you're going to purchase. It comes out standard going forward. All right, that was the demo. This is what I meant by collaborative workflow. I gave you an example of EMS collaborating, discharge. What about the emergency room? Any of you have ever been in the emergency room and told you're being admitted? How long you wait there after you've been admitted? How long you stand there with your family? Average in the US is about 4 hours. Europe, it's a little longer. During that period of time, you could actually deteriorate because you're kind of stuck in no man's land. The ED won't treat you, the A&E won't treat you because you've been admitted to the floor and maybe your NPO, they don't know the orders. You could actually deteriorate. What if standard kit was transfer the patient in real time using video collaboration and streaming data? Have a consultation between doctor to doctor, nurse to nurse. What about real-time consultation in the hospital? What's the standard service level agreement in most hospitals for getting consults? It's measured in hours. You were talking about lean, removing cycle time and delay. When I measure consult in hours, what happens to the patient? They often sit there doing nothing until the next step in the chain happens. What if it was each individual doctor's responsibility? If the cardiologist wanted a pulmonary consult, they took up their tablet, they opened a video conference, and they initiated it in real time. Now you're saying, well, wait a minute, that other doctor might be busy. Well, I know that the average encounter with a patient is 3 to 5 minutes, and I also know as a doctor, if I call another doctor and say I want to talk about a patient, they'll probably step out and talk to me almost immediately. How many times a day am I going to bother that pulmonologist or that cardiologist? Once, twice, 3 times, 0? The amount of interruptions will change. And that's what I'm suggesting here, real-time synchronous communication and streaming data, collaboration. That doctor should be paying attention to that person in the emergency room, that person about to come to the emergency room, that person about to be readmitted. That's the most immediate triage decision to make at that moment. And it's going to take them about 90 seconds to have a real-time conversation and then go back to what they're doing. What about at the time of discharge? Who do we sign out to? You know, nurses, anybody here a nurse? Do you sign out to anybody in the hospital between shifts? Okay. At the end of a shift, nurses collaborate. Anyone a doctor? Okay. Do you ever sign out to other doctors or patients? Yeah. But what do you do at the time of discharge? You sign out to who? I used to sign out to the taxi driver. Could you help Mrs. Smith up the stairs? Could you bring her there's no tight handoff. So what if it was your job to sign out to the doctor in the rehab hospital, the doctor in the primary care clinic? Again, it would take you 90 seconds, maybe even less, to talk to them doctor to doctor and convey the information. So this is what I meant by collaborative workflows. I may not have come up with the right collaboration, the right workflow, but I want you to start to think about within your organization, if you were able to collaborate in real time, share information and stream data, what process that you're doing right now that takes you hours or days, which involves multiple handoffs, could you collapse to real time to seconds with one handoff? That's lean. That's eliminating all cycle time, all delay. And if an error is going to surface, it's going to surface obviously because there's one handoff. So first-time quality will go up. Here's an example of where we actually did this in an ambulance system. In an EMS ambulance system, we actually built a local cloud in the ambulance. We connected the monitoring equipment and video conferencing. We tried doing it with access points. The connections always broke. But by building a local cloud in the ambulance and hardening the cloud so it was always available and always on, it didn't matter what I attached to it, including the EMS cell phones. I could emulate the cell phones in the cloud. And it didn't really matter if the cell phone could find a signal because the 40 dB watt gain antenna I put on top of the ambulance could sniff out a signal anywhere, even when your cell phone could never find one because the antenna was limited. I streamed all the data back from the EMS service to the ED in real time. As a result, I was able to treat acute MIs 40 minutes outside the hospital in real time. Door to balloon time became basically seconds. I rolled the person into the cath lab. They'd already been pre-medicated. Everything was done. The real consequence to the patient was half of them ended up with normal ejection fractions. And for those who are not doctors, that means after a heart attack, they had a normal heart. They didn't need cardiac rehab. They didn't have a disability because I instituted treatment immediately wherever they were. I'm going to switch gears and quickly talk about patient collaboration for 2 or 3 minutes. Here's a study, actually, that did something very simple. They decided to open up all the entire raw data in the medical record to the patient. Now, some of you are doctors, you're going, that's crazy. They're going to read the raw notes? Oh, it was some place called Deaconess Beth Israel, some little hospital in Massachusetts, a collaborative level 3 medical center in Pennsylvania, and a community hospital in Seattle. 100 docs, thousands of patients. At the end, a lot of docs were skeptical, but only 1% dropped out. Now, some of you are saying if you open up the data to the patient, they're going to freak out. They're not going to be able to handle it. They're going to jump off a cliff. They're going to commit suicide. They're not going to understand it. They're going to blah, blah, blah. All the fudge you can think of, you're going to throw at me. The fact is, 1 to 8% of patients had a hard time with it. 80% of patients felt better. No decision without me. Empowering the citizen, raising their ability to deal with you in the medical system, from doing something as simple as opening up the medical record to them with a portal so that they could view the data. And then, I don't even know where this number came from, but this is out of Annals of Internal Medicine, a pretty reputable journal about a year ago, okay? And 70% or so of people reported improvement in medication compliance from reading the notes. How many of you are doing extraordinary, expensive experiments? We got watches, we got reminder systems, we got dissolving pills. All they did was open the medical record. And they got a 70% improvement. Maybe it's because, I don't know, Dr. Blatt wrote a note saying 60-year-old obese, hypertensive, diabetic, truly non-compliant with all their medicines, at high risk for heart disease, scheduled for emergency stress test. I don't know. Maybe they read the note and got scared. Maybe when their wife read the note, she got really scared and said, you're going to take your medicine. That was an amazing outcome from just simply opening notes. Let's go back to Kaiser. Heard you talk about Kaiser being the emulation. Kaiser got a 1 electronic medical record and opened up that record to all their patients starting back in 2004. And as a result of that, look what happened to now, we're not talking hospital visits, we're talking office visits. Office visits started to go down dramatically. Again, this is a journal called Health Affairs, fairly reputable journal in the US. And scheduled phone visits went up. And it happened across specialties and across their whole system, such that by the end of 2007, about a third of their visits were now non-face-to-face visits. Most involving video, phone, but IM and chat and video conferencing were creeping in there. And by the end of 2012, what we then heard was about half of their visits, half, were non-face-to-face. You know what the cost of production of a non-face-to-face visit compared to face-to-face? Go back to my Saturday morning. You want to cut out 60, 70, 80% of your cost? This is the future. Collaboration between disparate actors and involving your patients and empowering them with data. These are system-wide changes. Internationally, telemedicine visits are skyrocketing into the millions across all diseases, all your chronic ones. Here's a little booth that's being developed in the United States where I can do a telemedicine visit. Takes up about 35 square feet, maybe 10 square meters. I can drop them in shopping centers, banks, anywhere there's an ATM, I could put a telemedicine kiosk and bring whatever specialist I needed there. And then if you don't like that, here was another little study, again, done at Boston Medical Center, where at discharge, instead of even having a nurse doing the collaboration and giving the discharge instructions, they had an avatar. A culturally specific, race-specific avatar give the discharge instructions to the patient. That lowers your cost, but it also begs the question, how many avatars can you supervise? So I'll end on one last thought. I've been talking about systemness. I've been talking about collaboration across firewalls. I've been talking about teams. I've been talking about fundamental cultural changes. So maybe the real value of the EMR that you're putting in place is not to improve individual transactions. It's the EMR as a foundational technology that allows you to avoid visits to the emergency room, allows you to avoid visits to the hospital, allows you to collaborate in real time, and allows you to self-empower patients so they can manage themselves. And when we look at the EMR in the future, what we really want to do is measure the ROI and the systemness of how the EMR allows me to collaborate and lower the cost of care, not just improve the care transaction between one patient. Collaborative workflows are where you want to go. Patient empowerment lowers cost. And the whole idea of visiting a doctor is about to change. So my call to action, think about those collaborative workflows. Figure out one that makes sense in your organization, and then figure out the cultural changes you need to get there and the IT that you need to support it. Thanks.
So we have time for a few questions for Dr. Blatt. So please, any questions? Yes.
From the European Association of Senior Hospital Physicians. My question is, when you talk first about avoiding readmissions at the hospital and trips to the hospital, do you consider this kind of medical advice or a medical act? I mean, the concerns of the European doctors is when you consider a medical act, the level of responsibility is completely different. So how do you see this advice? I'm 100% in favor of this, of course, but the concerns of European doctors is the responsibility when you give an advice or if this is a medical act.
This is a medical act.
The consequences are completely different.
This is a medical act. I'm very clear about that. This is not advice. This is diagnosis and treatment in a virtual capacity. And I point out that Kaiser's been doing it. I'll also point out that I have evidence to show that it's safe and effective for about 20 years. And to your point about liability, I can't cite one case anywhere I know of that anyone has been sued. If you can, please tell me about it.
Okay, right. Thank you very much for that. Right. Because the question in Europe is that the law...
It's a false question. It's what we call a red herring. It's never happened. It's FUD. It's what people are throwing up to say, you can't do this. You can't expose the record. You have to see me face to face. How many of you out there as patients have been to a doctor in the last... Think about you or your family in the last 5 visits you made to a doctor. I'm willing to bet on at least half of those occasions, the doctor never touched you. What the heck were you doing there? Any other thoughts, questions?
Just let me add this. In my country, in Portugal, we have several cases of these complaints about the medical advice or medical act. And in the legal point of view, it's so different that the doctors can be, if this is a medical act, they can be condemned. Is it advice?
Has anyone been condemned? Do you have a case where someone gave,
Oh, yes, in Portugal.
you do have distant tele,
But it's not by this technology. I mean, it's the advice or...
I'm talking diagnosis, treatment, not advice.
Yes. Thank you very much for your information.
Other questions? Yes.
My hospital in the UK, we have developed telemedicine for mainly the elderly in nursing homes. And two findings. One is that we've never, about once a month we would need the doctor. It's the advanced nurses that will handle the diagnosis.
Mm-hmm.
And maybe the patient will have to come to A&E, but not that often. And secondly, the number of calls is that because we have to have the telemedicine unit manned 24 hours a day, 7 days a week, we need a much larger population to serve. So in England, we would need a number of hospitals collaborating for this one unit.
What I like about this is you're not having a telemedicine room on the other side of the equation. If I want to get you, I'm going to call your tablet, your device, your phone, and I'm going to get you as the clinician on the receiving end. I might have a switchboard service that directs me to the right person in the audience to take the call. But the notion of going to the telemedicine center, that never worked. It was too expensive, it wasn't scalable, it was used too infrequently. This is a way to actually turn what you're doing with your kids and using Skype and personal video into actually telecare. And I think it should become standard kit, not the exception.
Yes.
I really like these ideas, and if
Thank
we
you.
extrapolate and say these ideas really take off, how would you see them really developing in terms of globalization of healthcare? I mean, I could go
Wow.
on holiday in Fiji, and I could talk to my doctor in the UK, but there's more than that. You could be helping people all over the world, regardless of the country. How do you see that developing?
It's a generation, slowly, but I think it's like interstate and international banking. I think you're going to see some level of standardization. And also competitive advantage just tells me that services will migrate to the place where they're offered the best and there's the best cost platform. I think you'll see emerging markets and emerging economies taking advantage of this first because they won't have to build bricks and mortar. We've given advice to people, let's say in the African different ministries of health, do not do what we've done in the West. Do not build the Western healthcare system. It's managed to bankrupt every country that's tried to do it. We can't sustain it. We can't deliver services to our citizen. You have a unique opportunity from the ground up to build a virtual healthcare system. Now that might mean the doctors in their country get all up in arms because, again, it's a lot about guild protection. I want healthcare to be local. I don't want healthcare to be, if you will, borderless and be able to take advantage. But one hospital that we're working with is building what we would have called a community access, critical access hospital. It's supposed to have maybe 25 beds, but when you walk into a room, it's going to have a telepresence unit. And instead of having a department of nephrology, dermatology, ophthalmology, blah, 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 every department, the department's going to be virtual. And you'll be able to access the specialist for whatever specialty you want, essentially virtually. And if, let's say, you need a procedure done, you'll have someone oriented towards the procedure, local at the hospital, put on a cast, do an endoscopy, start an IV, and you'll have therapists. But the super specialists that make up the department might be scattered across the country. Wow, that's a really different way to have a hospital staff. And that really implies different ways of organizing and a different culture about what we do. But that goes back to the idea of collaborative workflow, real-time video conferencing, and streaming data.
Collaborative workflows, in my opinion, are a combination of real-time communication and also asynchronous communication.
They can be, I agree with you.
In the hospitals in Copenhagen, most of the communication between the clinicians is phone calls. And actually, it's also that I have a patient that I want you to look at in the next 4 hours. It's not critical difficult, but can you please come and look at this patient? And the only way that they can give that information is right now calling the other person and say that and disturb them in their work process at the moment where they get that information. I think it's very important that collaboration is a combination of asynchronous and synchronous communication, depending on what information you need right now.
You know, when I talk about working collaboratively and I talk about working together as teams, I'll also admit that probably 80% of what I would do as a primary care doctor, I don't need to collaborate. If I want to sew up a cut, give you a shot, treat your sinus infection, help your back pain, or treat your UTI, I might be able to do it virtually, but I probably don't need to collaborate. It's that 20% or so where collaboration makes a critical difference, the readmission. That's where all the money is being spent and wasted. That's where I need the synchronous real-time collaboration. If the consult's not an emergency, then the patient could wait. But you're in the hospital, most of the time when I need a consult, it's probably fairly urgent. Even if it's not urgent medically, it's urgent at the systems level.
Right.
You're taking up a bed, you're spending time in the hospital, you're away from your family. I want you to go through that experience as quick as possible. I mean, how would you like it if a store clerk told you, look, I know you want a shirt, but could you sit down and wait 2 hours? It can't be urgent, it's not an emergency. You know, I'll get to you. You wouldn't like that.
Yes.
Yeah, I just want to comment on that because I think in that situation, like you said, today you make a phone call, but in a hospital, at least of any size, there's probably several specialists that you could talk to. So you really want to talk to the one who's free, and that is the sort of intelligent contact that you can do with technology that you don't do now because you dial the number of your friend. You get him out of surgery. And the fact that his colleague that has the same qualification might have time available right then.
Now you're brainstorming about collaborative workflow, and you're coming up with a workflow to make it happen. That's exactly what I wanted you to start thinking about.
Yes.
I'm a hospital CEO, and not only do I like what you're showing, and I believe it's not just technologically credible,
Yes.
I think it is also practical. The key issue, from my standpoint, is not about collaboration. I think it can be very useful. The issue is reimbursement models. Because, you know, we quite find that at the end of the day, the disparate reimbursement models across any nation that exist between what is a professional service, a clinician, how you pay a nurse, how you pay a doctor versus how you pay a hospital, are big issues with respect to adopting these sort of evolving models. And so, you know, I don't want to be idealistic, I want to be practical. And quite often I find that when I come to sessions like this and I see technology companies like yours advance these ideas, which I buy completely. I go back to my shop, and then I have to figure out how on earth do I get it going.
You know, if you're dealing with fee-for-service or volume and you're getting paid for volume, and I just showed you a way to decrease 40% of your volume, you basically want to shoot me. I mean, it doesn't make any sense. It's an economic non-starter. One of the reasons I picked Kaiser as a payer-provider organization is because it's aligned and it makes sense within the Kaiser organization. It makes sense within the US VA, the military. Any organization that's a payer-provider organization, any country which is facing social deficits because they can't meet the obligation to give their citizens care, it actually makes sense. What you have to do is devolve the care model down to the hospital or to the group system level and actually pay them for outcomes and pay them for collaborating. In the United States, there's a move towards this kind of payment. It's called ACOs, and that's why this actually makes sense for the first time in 50 years in the United States to be talking about this. I think it does not make sense where fee-for-service reigns, but then I'll go back to citizens are going to start to see the availability of getting inexpensive care by picking up a tablet and contacting a doctor in another country or remotely. And because the care service delivery could be $20, $30, I'll pay for it out of pocket. And I might call it video concierge, and I'll get most of my treatment and diagnosis, not consultation, treatment and diagnosis using a $20 or $30 service delivery model, which is going to fundamentally go against the fixed cost of the hospital system. It's just economics. It's going to happen.
Right. And if you look at the data from the Hawaii case that Mark cited, certainly hospital administrators have some challenges there, but the average physician is pretty happy with that model, and it hasn't had a negative impact on them economically, and they can do more visits at a more aggressive price point. They have more hours available to see patients because they're willing to do it from their home or while they're in motion. So the physicians kind of can split either way on this stuff, but certainly if you have a big investment in an asset-based shop, there are going to be some issues to address here.
Yep.
We have time for one more? Yes.
So I wanted to make a comment, first of all, a great presentation.
Thank you.
At the end, you made a point talking about the EMR as
Yes.
a foundation. And I would like your comments because often we see two separate sides, the EMR and a lot of spending in there, and then collaborative workflows that start to emerge. The two are not united. And we've seen actually in a recent IDC paper that the real value from collaboration and communication comes when you embed that unified communication into line of business, into the EMR. And you could see also analytics into that EMR, you could see patient relationship management out of that. So that's the vision. And
Yes.
I think it's important that when we say EMR as a foundation, EMR an extended
Totally.
EMR.
Your comment is spot on. I think clinical decision support systems, artificial intelligence, and I think voice-driven as a way of interacting with the compute entity is definitely the future. I was talking about a foundational model. We were actually going to do a workshop right after this on apps versus applications going forward. I think it's an interesting debate about what we're going to see get created going forward. The cost of EMR implementations is skyrocketing. There was a nice Fortune magazine article about how one of the leading EMR vendors in the United States is managing to bankrupt hospitals. I think we've reached the worm is the turning point. So I'd love to hear other people's opinions about apps versus EMRs.
My wife's employer just finished finalizing the capitalization of $500 million to buy EMR. And the fact that the chairman and the rest of that board aren't being terminated for that decision is just shocking to me.
That's a lot of money, and only very few organizations like the one his wife works for could afford that.
Oh, no.
Thank you, Mark.
Thank you, Mark.
So I'd like to invite on stage Javier Ferrero. Again, Javier is the CIO of the Healthcare Quality Agency in Andalusia, and he'll share some stories about mobile health, the strategy that he is driving in his organization and across the region.
Okay, thank you, Max. First of all, I would like to thank IDC and Intel for this invitation. My presentation will be focused on mHealth, always from the point of view of quality and patient safety. Okay. So, this will be the contents for the next 20 minutes. Let's say some words about mHealth. I will describe you some characteristics of the Andalusian public health system and the organization I work for, which is the Andalusian Agency for Healthcare Quality. Then our experience in accreditation and how turning it into mobile may help physicians to improve and optimize their time. And for ending, just a project on mHealth integration, personalization, and an initiative we are carrying on a mobile health application regulation. Okay? So, this picture was taken in 2005 when the faithful gathered to bid farewell to Pope John Paul II. It's an ordinary picture, okay? Nothing strange. But if you compare with this one, now we see the differences, okay? This is the welcome to the new Pope. It was taken this year. It makes a difference of 8 years time between them. Then the previous one is strange, isn't it? So both pictures reflect a very rapidly changing world. What does the World Health Organization say about mHealth? They say that the use of mobile technologies will transform the healthcare delivery service. And it's true. Where we don't reach with roads, where we don't reach with infrastructures, even with information systems, we have mobile. We have mobile phones, so you can take advantage of that circumstance. If you have a look at some reports on application market phases, we clearly see that we are in a second stage, a second phase on commercialization. But to achieve some milestones like integration and regulation, we have to wait till 2015, 16. That makes 8 years from the beginning. Many things happen in 8 years, as we have seen. So why not try to shorten that time and try to get those milestones and try to integrate and personalize services through mHealth technologies? So let's travel to Andalusia, okay? It's the southernmost region of Spain. It's well known because of their cultural heritage, colorful landscapes, beaches, of course. But, okay, we have 8 million inhabitants, and we receive more than 20 million tourists per year. Tourism is very related to health. There is an European directive coming next in October who will regulate cross-border healthcare delivery to patients. That means, within certain restrictions, the possibility of choice between the European Union when receiving healthcare treatment. So quality and patient safety indicators will become more relevant even. Okay. Just some figures to give you an idea of the scale of our public health system. Okay, in Spain, I didn't say that. In Spain, health competencies are transferred to region. Okay, Andalusia is autonomous in political strategies on healthcare. Okay, we have more than 40 public hospitals. We have more than 1,500 primary care centers. There are more than 100,000 professionals working for us. The budget will be reduced, of course, half that number, sure. And we have more than 3,000 pharmacies. One of the main characteristics of our healthcare model is that it's a patient-centered model. We work on 3 points, which are professional competencies, who is going to provide the healthcare, the clinical management, where you are going to receive the service, and process management, how you are going to be treated. We have one of the most striking achievements in Andalusia is the massive use of infrastructure technologies in our system. We have a centralized appointment system. We have more than 95 million appointments per year. It's available through the web, through SMS, through mobile applications, and of course on the phone. But also, any single patient with his health smart card can obtain directly his medication through the pharmacy, through any pharmacy in the whole region. And pharmacists can network with doctors to talk about drugs, interactions, and so on, okay? And with the project Click Salud, each individual patient has an electronic health record with the most relevant content of health, available at anywhere and anytime. Well, inside this system, we have the Andalusian Agency for Health Quality, which is the public foundation in charge of promoting and developing quality and patient safety policies. So what we do mainly is to address some certification processes, okay? In the domain of health centers, okay, health center certifications and professional skill certification. Our goal is excellence, and in Andalusia, each professional can certify his skills through the submission of evidences and his daily practice. We don't look for the knowledge, we look for the daily practice. Why? What for accreditation? We are looking for those objectives: to favor continuous professional development and excellence in care practice, to promote efficiency, to reduce variability, to share knowledge and best practices that links with collaborative networks between centers, to improve health centers' organization and collaboration. Well, these are some characteristics of our model, which is based in a self-assessment phase. And there are some milestones described, like we have identified more than 1,500 best practices by each individual professional. We have reached benefits for more than 500,000 patients. And we have got more than 200,000 interactions between professionals and our organization. These are some figures. We have more than 700 health centers involved in certification. We have more than 20,000 professionals ongoing and accredited. We also have training activities and web pages accreditation. Well, our organization is acknowledged by EFQM, by ENAC, is a Spanish accreditation company, and we are one of the 13 companies worldwide accredited by ISQA. Okay. The only one is in Spanish language, and the only one which is a regional one. But it's not only a question of Andalusia. Portugal has adopted our model for the entire country, and we are taking some actions mainly in South America to expand our model. So, more concretely, I would like to show you how any clinical challenge may conduct to a clinical reality. We have the problem for diabetes. The World Health Organization says that by year 2030, it will be the 7th death cause worldwide. We have some standards on diabetes. We constitute an expert committee. This committee translates the standards to a certification manual. We get those standards to the doctor. Why not through mobile technologies? And then we have the best practices for the diabetes. What objectives do we persecute when developing a mobile application for accreditation? Okay, we try to facilitate learning and continuous improvement of health professionals. We try to deliver health services, bringing best professional practices to the point of care, okay, to the bedside. We try to optimize the working time of health professionals, reducing their administrative burden. And, of course, regarding healthcare centers, we try to increase the efficiency of the processes of the health centers. How? By developing an application especially designed for Windows 8 platforms powered by Intel, okay? So we already have information systems who manage the whole process. There is no paper exchange, well, except for an original of the job certificate required before starting the process. But we are sure that with mobile technologies, we can reach more functionality and we can optimize the working time of the health professionals. These are some of the characteristics. I don't want to be very heavy, but we're providing functionalities like communication areas, real-time chat with coordinations, tutors, other colleagues into accreditation, document sharing, social network integration, access to information resources, links to meta-search engines. We simplify the submissions of evidences. Nowadays, when a healthcare professional has to submit any evidence, he has to take the personal health record and has to copy it, to select, take it home, sit in front of the computer and scan it and submit it to our systems. With the mobile, it's as simple as taking a picture and uploading it to our systems. We can take advantage of push notifications. We can plan their certification process. We can make many things with the mobile. Intel has kindly elaborated a case study with this experience. So if you want more further information, it's at your disposal. Okay. Let's change a little bit. I will tell you in a few slides some characteristics of a project regarding integration and personalization in healthcare and patient safety. I've been focused on healthcare professional side, but now we are going to focus on patient safety. We have a project called It's in Your Hand, which tries to develop and integrate a set of mobile applications, integrating it with the citizen health folder. Concretely, we have developed a service connector, which integrates with clinical information systems and publish certain information on the citizen health folder. We had developed 4 mobile applications. You have Ask About Your Health, Recuérdame, sorry, it's not translated, but it will be like Remember My Medicines, Incident Reporting, and Surgery Checklist Verification. We have achieved more than, I don't know if thousands of downloads from more than 30 countries, but we think that our goal is not to provide a worldwide solution. We have to give value to our customers, to our patients. So we have to personalize these services. With Ask About Your Health, we are providing an application to manage the questions and answers prior to a medical consultation. With Recuérdame, we are providing with an application to manage, especially for chronic and elderly people, the medication, allowing them to take pictures, to have push notifications, to schedule the the drug, medication, etc. Incident reporting, that means to communicate safety incident reporting, and surgery checklist verification, which allows patients who are going to face a surgical operation to complete the previous recommendations prior to the treatment. In this case, we are allowing real-time communication between patients and healthcare professionals. Nowadays, I think that there is 4% of surgeries that are canceled the day before because patients don't follow the recommendations. With this application, if you will integrate it into the citizen health folder, we are avoiding that 4%, which means a lot, huge quantity of money. We are piloting this project in the Coastal Hospital, in Puerta del Mar in Cádiz, and in a high-resolution hospital in Seville. And last, we have an initiative regarding application regulation, which we have called Distintivo APP Saludable, Healthy APP, which tries to give some confidence into the use of health applications. It's well known that there are thousands of health applications in the markets, but there is no one there, no one behind. Is any doctor behind some applications? Well, it depends. For example, in the case of teledermatology, there is a study of Medline which states that 30% of this application don't work. And there are people who realize his cancer, his melanoma, on the diagnosis of the application. It's very hard if it doesn't work. So we think that the administration has to be behind these applications. First, 1 year ago, we published the first reference guide for health apps in Spanish language worldwide. There was some references from the FDA in the US and from Haptic, but in Spanish there was nothing. And we intended the use of this guide for developers as the creators of the applications, for healthcare professionals, because they are intended to prescribe mobile applications, and for users, because they have to know how to distinguish good applications from bad applications. And finally, in May this year, we have launched the APP certification program, which is called Distintivo APP Saludable, and it has a self-assessment phase. Then we conduct an evaluation, and finally, this month, next month, maximum, we will have our own app library, the way the National Health Service here in England has. We are currently evaluating more than 40 projects. And that's all. Thank you very much.
Thank you, Javier. Any quick question from the audience before we break for a few minutes? If not, maybe just one quick question from me. You talked about how the applications have been used for self-assessment and accreditation, but you've also mentioned that this technology can have an impact on collaboration, can have an impact for the citizens and the professional beyond the core business of the Healthcare Quality Agency. Can you quickly elaborate on that?
Okay, I have described our business, but in fact, healthcare centers accreditation is tightly linked to organizational and strategic goals. I mean, in Andalusia, the stimulation for the accreditation comes from the regional government. Mm-hmm. Those health centers that are accredited have more autonomy, have more budget, And we have conducted some research projects that shows that they have better results than those ones that are not accredited. So there is a very tight relationship between one and another.
Very good. Thank you, Javier.